me host or, oh, awesome. Or just record. Great. Thank you so much. Cool. Awesome. Thank you, Sabrina. And eosin is an acidic dye, which binds bases in tissues, which are generally the cytoplasmic proteins and organelles, et cetera. This dye has a pink hue. So this tissue is considered acidophilic because or eosinophilic. Eosin, again, because of the pink, the name of the dye is eosin. So basophilic versus eosinophilic are generally the two names we use to determine sort of more bluish versus more pinkish. Additionally, immunohistochemical stains detect very specific proteins in the cytoplasm or nucleus that you may have run into, and if you've done laboratory research or whatever. These are antibodies conjugated to dyes, and the antibodies are specific to certain proteins, either in the cytoplasm, the nucleus, or even, in fact, the cell membrane, right? So these bind to those specific proteins in those specific locations. And then those dyes, those conjugated dyes, are the ones that we see, in this case, brown. There's always a background counterstain, in this case, blue. So you see the tissue below it. Otherwise, you're not going to be able to pick up where you are. So the blue is the counterstain, the brown, or for that matter, the red, are the reactive tissues. There are also general stains that are not specific to a certain protein, but more generically related to various biologic structures or compounds. So, for example, GMS binds carbohydrates, any carbohydrates, in fungal cell walls. So we can pick up fungus with this stain. Congo red stains all kinds of amyloid, no matter what necessarily protein it's made out of. And this stains red with a blue counterstain. Something like mucicarmine binds all kinds of mucins. In this case, in the respiratory or gut epithelial cells, you can see these goblet cells staining in red with the yellow counterstain. Okay, awesome. Any questions on that? Okay, so once we, a lot of head and neck pathology ends up being more tumor related. So yes, there are inflammatory lesions, which we'll talk about. Yes, there are infections, but honestly, a lot of our work is with the neoplastic side of things. So I'm going to sort of go through a little bit how we name and describe tumors, because you may have to realize this stuff for your boards, and you certainly will deal with it in your clinical practice. So when you have a mass forming lesion, what could it be? It could certainly be something like inflammation or a scar, or a keloid forming a larger lesion. You could have a hyperplasia, a growth of tissue in response to some kind of external stimulus, or a neoplasm, right, which grows independently because of its own sort of internal genetic drivers. All right, so we realize neoplasms as clonal proliferations that are unrelated to any outside stimulus once that initial genetic driver, has hit. So we can see non-neoplastic as well as neoplastic mass-forming types of lesions in any body site. So just as a reminder, from basic pathology, a neoplasm is thought to be derived from a single progenitor stem cell, which is usually a stem cell. So that therefore these are called clonal or monoclonal. These genetic drivers have conferred some kind of growth advantage on the cell due to these genetic or epigenetic changes. And now it proliferates independently, right? This is different from hyperplasia, which is in response to some kind of physiologic signal, some kind of hormone that's circulating in the body, and is not monoclonal, it's polyclonal, right? So, the red cell divides, the green cell divides, the orange cells divide, not just that single stem cell, but all the cells in that milieu that is responsive. All right, so then within neoplasms, we have benign and malignant neoplasms, right? So malignant neoplasms, of course, considered those that essentially have the potential to cause significant morbidity and mortality. Okay, so benign and malignant tumors are named according to essentially their presumed tissue of origin or tissue of differentiation and their histologic appearance in tissue. So we have epithelial tumors that generally are referred to benign as adenomas, malignant as carcinomas. Mesenchymal tumors that are malignantly called sarcomas, right? Lymphoid lymphomas or leukemias, melanocytic melanomas. The benign names can vary, Benign mesenchymal tumors can be fibromas, chondromas, lipomas, right? Sort of depending on their tissue type. Certainly benign melanocytic lesions are nevi. There are these very rare types of tumors that are differentiate to both, for example, glandular and mesenchymal phenotypes. These might be called something like an adenofibroma or a carcinosarcoma, although these are rare and this nomenclature can sort of change over time. But the big ones are bolded, as you can see here. All right, so nomenclature for carcinomas depends on the type of epithelium it either resembles or is derived from. So certainly squamous cell carcinoma generally is derived from squamous epithelium and it looks squamous. So it recapitulates this pattern of cells with intracytoplasmic keratin, with keratin pearls. Adenocarcinoma, on the other hand, is more of a glandular type of carcinoma that can be derived from essentially any gland in the body. So salivary gland, breast glands, prostate glands, gut glands. So all of those carcinomas that arise in those sites are adenocarcinomas. So we generally want to specify, or in this case, this is a salivary type of adenocarcinoma, specifically mucoepidermoid, but you can have mammary carcinoma, gastric carcinoma, adenocarcinomas, et cetera. Okay. Nomenclature for sarcomas depends on, again, the type of mesenchymal cell they sort of resemble or differentiate towards. So you can have, tumors or lesions of blood vessels, which are benign, that you might call the hemangioma, but a malignancy that is starting to recapitulate blood vessels, both phenotypically in terms of what it looks like and immunophenotypically in terms of what it stains for, all right, would be an angiosarcoma. Similarly, another example, a benign lesion of cartilage would be a chondroma, a malignancy would be a chondrosarcoma, just as a review of these terms. Okay, so then when we are looking at a neoplasm that we aren't necessarily certain what it is, on first look, we go through a systematic approach from, outside to in, top to bottom, to sort of determine what we think this lesion could be. So we're going to look at the border, at the cellularity, at the growth pattern of the cells, at the shapes of the individual cells within those patterns, at the state of differentiation of the tumor, and what other features of malignancy might be present. So let's start from the border. Certainly something that is well circumscribed, has a clean edge. This generally can imply something benign or something low-grade malignant. Generally something that is infiltrative, invasive, or poorly circumscribed. You can see these nests of cells infiltrating between this normal cartilage in the middle here, usually implies something of malignant behavior. As I will say over and over again, these features are not uniform. So just because it's well circumscribed doesn't 100% mean it's benign. And just because it shows some infiltration doesn't 100% mean it's malignant. We have to take all these features together in order to determine benign versus malignant, because there's not necessarily a single feature that will push you in one direction or the other, with rare exception. Okay. All right. Then moving on higher power, we look at the cellularity. Generally something that is hypocellular or paucicellular or low cellularity. Again, the nuclei are spaced far apart with lots of stroma in between, in this case, collagen. This may, again, imply something benign or something low-grade malignant. Hypercellular means many nuclei packed together with little cytoplasm in between or little stroma in between. This generally can be something more higher proliferative or higher risk of being malignant. Okay, growth patterns of those cells. In the above image, I gave you two examples of two spindle cell lesions. But cells can be of various morphology. In this case, I'm giving you more plump cell morphology, where these cells are growing in nests, sort of rounded structures, or cords or trabeculae, which are more sort of elongated. This pattern implies some kind of cohesion between the cells, such that they're not just loosey-goosey, right? There's some kind of structure. This can either be in an epithelial tissue, in a melanocytic tissue. Generally is not so common in lymphoid or mesenchymal neoplasms. So lymphoid or mesenchymal neoplasms generally have less cohesion between those cells, and they show up as sheets. So you can see here on the right, there are sheets of these rounded lymphoid cells. And in the above area, there are essentially sheets or long, fascicles of these mesenchymal spindle cells without any sort of glandular structures or nests. Okay, so that could also clue us in to the tissue type of these cells. As already mentioned, the cell morphology generally ranges from something plump or epithelioid to something spindled. Epithelioid means there's lots of cytoplasm. The nuclei tend to be larger and ovoid and or round. And this either is suggestive that it could be of epithelial origin or resembles something of epithelial origin. On the other hand, spindle has elongated nuclei with sort of tapered cytoplasm. This generally implies something of mesenchymal origin or something resembling mesenchymal origin. So just, to put things in perspective, most carcinomas are epithelioid, but we know that cells can undergo an epithelial to mesenchymal transition, and some carcinomas appear spindled, right? So those we call spindle cell carcinomas. Sometimes you may see them referred to as sarcomatoid carcinomas, right? Oid, meaning they look like sarcomas, but really they are of epithelial derivation. They behave and they are treated like epithelial malignancies, like carcinomas. Conversely, you can have mesenchymal to epithelial transitions where there are some sarcomas that appear epithelioid, right? So we have one sarcoma that is called epithelioid sarcoma because it looks plump. It looks like this, but it's actually of a mesenchymal tissue origin, okay? So just to get those terms out there, so when you see these in the reports, you sort of understand what that means. Okay. Next, we look at tumor differentiation. Sort of overall, does a tumor resemble its normal counterpart or not? So these are both tumors of the same organ. Does anybody recognize the organ based on the picture on the left?
Thyroid.
Excellent, thyroid. So this would be a well-differentiated thyroid neoplasm. The one on the right would be a poorly differentiated thyroid neoplasm. Generally, something that is well differentiated implies a lower grade or a better behavior. Something that is poorly differentiated implies a higher grade or a worse behavior, certainly because it's sort of gone off the edge, right? It's gone off the deep end. It no longer looks like its originating state. All right. Once we get through all of these items, we do want to look for some features that may be more specific to malignancy. Okay. Things like nuclear pleomorphism or anaplasia. Anaplasia literally means reverse differentiation, right? So these cells are sort of becoming primitive. They are large, they are misshapen. The nuclei are hyperchromatic or dark, probably meaning that there are lots of copies of the chromatin in there. So they sort of pack together in a cell and become very dark. Lots of mitoses might imply something of rapid growth. Certainly necrosis, in this case, this grungy pink material in the center, essentially means this lesion is outgrowing its blood supply. It's growing so fast to outgrow its blood supply, areas are dying. This is a potentially very good indicator of something malignant. I will make an additional word, however, on mitoses. Mitoses that are morphologically normal. So, go back to grade school, right? Even prophase, metaphase, anaphase, telophase. All of these morphologies of nuclei are normal and can be seen in benign lesions, in hyperplasias, in malignant lesions. However, once you start seeing something that is morphologically abnormal, like a tri or a tetrapolar, this kind of implies that the DNA is no longer stable. There may be 3 copies, 4 copies of the chromosomes. This implies abnormal DNA, again, an abnormal cell division. So this is essentially more diagnostic of malignancy specifically, right? Rather than just a proliferative state. Okay, because you shouldn't have, tetraploidy in a benign neoplasm. Okay, so just as a reminder, generally things on the left favor something benign or low-grade malignant. Generally, something on the right favors something frankly malignant or high-grade malignant. The borders, the cellularity, the state of the nuclei, the presence of the mitoses or their morphology, the necrosis and differentiation state. But as I said before, Some benign and malignant tumors can have overlapping features, right? So a benign lesion can be somewhat infiltrative at the periphery, and a malignant lesion might be circumscribed in areas, okay? So the presence of a single feature on one or the other side doesn't automatically mean that it is what it is, but again, all things in consideration. Okay, questions based on that before we move on into the more specific lesions? Okay, awesome. So we'll start in the oral cavity, oropharynx, and move on to sort of the larynx. And so we'll talk about a number of infectious and neoplastic diseases. So just as a reminder of what normal squamous epithelium looks like, we know that squamous epithelium lines the oral cavity, it lines the larynx, it certainly lines, some of the, tracheobronchial tree, especially if there's injury, right? Even in the, now we're getting a little out of context, but even in sites that can have normal squamous epithelium present, but also other sites that have, for example, respiratory epithelium that are responding to injurious stimuli, right, like smoking, can undergo squamous metaplasia, okay? And hence you can get squamous lesions in sites that are not even necessarily primarily, natively squamous, okay? Just as a reminder. So squamous looks like stratified, right, meaning multiple layers. It has a distinct basal layer here. You can see these cells lining up really nicely at the base, and it matures to the surface, meaning these cells, the nuclei sort of become flatter and the cytoplasm becomes more abundant with increasing intracytoplasmic keratin, which in this case looks sort of pinkish or pale purplish, okay? So some of the more common diseases we see of the oral cavity are going to be presented first. So things like lichen planus, which is this autoimmune mucositis, generally an asymptomatic lesion in adult females, and this very characteristic clinical picture of so-called Wickham striae, which are these white streaks on top of red patches. And so histologically, what this translates into, you may read these words of so-called sawtooth reedy ridges, meaning the epithelium has these downward sawtooth pointing edges. Within the stroma underneath the epithelium are these dense chronic inflammatory cell infiltrates, sometimes called band-like, okay? When lichen planus is suspected, you may want to take a biopsy for immunofluorescence, which I will show you specifically in another slide what that might look like. But once a biopsy is taken for immunofluorescence, we apply these antibodies to it, and deposition of fibrinogen at the basement membrane is quite a specific finding in this clinical and histologic context. So we are able to confirm a diagnosis of lichen planus. Other diseases for which immunofluorescence is helpful are those that are the vesiculobullous diseases, i.e. pemphigus vulgaris and bullous pemphigoid. So depending on where the blister occurs, whether it's within the epithelium, i.e. suprabasal, right here you see the epithelium is detached from itself, the basal layer remains below, or subepithelial, where the entire epithelium detaches and all that's left on the bottom is the basement membrane and stroma, et cetera. The difference is because the antigenic properties are either in the intercellular sort of desmosomes, causing breakage between the cells, or at the basement membrane, right, causing breakage at the basement membrane. And so we can again apply immunofluorescence where we'll see highlighting of the antigen between the cells, right, or highlighting of the antigen below at the basement membrane level, okay? I don't know, my way to remember this is that pemphigus vulgaris is fishnet style pattern, so it's vulgar fishnets. Okay, that's just me. So when you suspect clinically either lichen planus, whether it be, intact, erosive, or vesicular, or one of these other bullous diseases, a biopsy for immunofluorescence is recommended. And so generally we'll take a couple, or we'll recommend a couple. one biopsy for sort of just routine processing in H&E in formalin, because we want to see the H&E morphology. Generally, we would recommend either a biopsy at the edge of the lesion so that there's interface with normal, or perhaps a biopsy in the center and a biopsy of adjacent normal for comparison. And then a biopsy in for immunofluorescence. I know some of you may have had the opportunity to communicate with us about these cases, but we do have Zeus or Michelle's fixative available for you. If you see a patient in clinic or in the OR or whatever that you might need this fixative for, we can send some to you, and you can just put it directly in there and we will process it for immunofluorescence. Or you can send it fresh, no formalin, no saline, no nothing, just fresh, and we can place it in the fixative and do immunofluorescence. So in any case, it'll get done as long as you let us know what you need. Yeah, right. Wasn't that a good movie? I didn't watch it this Christmas, but okay. So moving into the subepithelial lesions. I put these here, you know, honestly, more because these lesions are pathologically similar. They're actually quite clinically different. So epulus or congenital epuli tend to be these exophytic masses on the alveolar ridges of babies, of newborns. They are composed of these sheets of cells with very granular cytoplasm, very distinctive cell borders. On the other hand, granular cell tumors tend to be present more on the adult side. They are more sessile masses with, you know, a little bit of raised. They certainly can be on the tongue, in the larynx, in the skin, and the esophagus. These guys can be anywhere. Histologically, they are also composed of these cells with granular cytoplasm and sort of indistinct cell borders. The things that are interesting histologically are that granular cell tumors in adults are thought to be modified, perhaps Schwann cell derivatives. And so they stain for markers of Schwann cell derivation, meaning S100 and SOX10. So, you know, Schwann cells as the cells that, you know, ensheath your nerves. These are not necessarily that function. They're just these cells that express these Schwannian markers, and they occur in the subepithelial region down here. They can have quote unquote pseudoepitheliomatous hyperplasia at the top. If you ever see this word, it basically means, so the old word for squamous cell carcinoma used to be epithelioma for whatever reason. So this is basically pseudo squamous cell carcinomatous hyperplasia, meaning the surface epithelium on top is very proliferative and branching, almost resembles squamous cell carcinoma, but in fact, clinically does not behave as such and is very closely associated with being on the top of a granular cell tumor. You take these out, they're fine. The patient doesn't have carcinoma, never any clinical ramifications, but it's just a histologic sort of mimic. Okay. Other lesions that we can see in the subepithelial area are a so-called pyogenic granuloma or lobular capillary hemangioma, which are these sometimes red or bluish lesions that pop off of the mucosa. But the money is underneath, right? So you can see here's the surface squamous epithelium. With underneath are these lobules, right? Lobule of these dark cells. And so you have to go on higher power to investigate what those dark cells are made of. But they are essentially, as you can perhaps see here, made of these slit-like capillaries filled with red blood cells. And on higher power, you can perhaps appreciate that a little better. They are proliferative, they grow, so they can be mitotically active, but these are morphologically normal mitoses. And so, you know, quote unquote, lobular capillary hemangioma describes what it is and is the term for it. Sometimes these can be called pyogenic granulomas.
Dr. Cipriani?
Yes.
Quick question.
Mm-hmm.
I've seen it described where like epulus is kind of a subset of pyogenic granuloma. Have you seen that before or?
No.
No. Okay.
So it shouldn't be.
Okay.
They, clinically, they may manifest similarly as a
Okay.
protrusive lesion off of the gums, but really histologically, epili are very specific, as you can see with these very distinct granular cells in the stroma. Pyogenic granuloma, to me, is also a very specific diagnosis of this lobular capillary hemangioma. I will maybe suggest that sometimes the term granuloma, at least what I see clinically, is used as a non-specific term. So I know sometimes you're sort of plucking off laryngeal granulomas, or there's again, a tissue on the gums that you may say, okay, that's a granuloma. But I would argue that it could be used as an overarching term, but is actually not specific. And so we would rather be specific and use these terms of epilus or of lobular capillary hemangioma to reflect the underlying disease process, even though clinically there's sort of these pedunculated, quote unquote, what might be referred to clinically as a granuloma. Does that make sense?
Yeah, that makes sense. One of our textbooks just kind of like lobbed them in together. So I was just wondering.
Got it. Cool. Yeah, it's funny, now that we're on this topic, I will divert for 1 second. So, granuloma from a histologic and diagnostic perspective is specifically a collection of histiocytes that we tend to think of as, a caseating granuloma, right? Where there's histiocytes at the edge and necrosis in the middle, and that's like tuberculosis or fungus, or a non-caseating granuloma where there's no necrosis in the middle, and it's just this collection of histiocytes and giant cells that may, be diagnostic or suspicious for something like sarcoid. So when we say granuloma histologically, we mean those very specific nodular structures composed of histiocytes. Again, another place where that term can be overlapping. And so when I sometimes see a granuloma, quote unquote, removed from the trachea, or a stomal granuloma, that's basically not a histologic either, vascular hemangioma or a collection of epithelioid histiocytes. That just tends to be reactive, like fibrosis and granulation tissue. So again, just maybe a difference between those terms in various settings. But I just wanted to mention that because it comes across, our desks a lot, these terms. And so I think it's good to sort of be clear about it. Okay, awesome. Other questions? Thank you for asking that. Okay. All right, moving into some of the infections of the squamous sites. So one of the, again, more common infections we see is candidiasis. And so, thrush, certainly you can see the white spots, you can wipe them off, you can be pretty certain of what it is. But sometimes there is candida that invades the epithelium and causes the epithelium to become hyperplastic, and you can't scrape that off, right? And so this may come to us for biopsy because it looks kind of white. It may be suspicious, some kind of, leukoplakic lesion. So we sometimes can diagnose hyperplastic candidiasis when we see a very, very thick epithelium, right? You can see these long kind of downward pointing bulbous redi. We see these neutrophils in the epithelium, not just in the stroma, but actually in the epithelium. And then you can see these pseudohyphae just piercing right through the epithelial layers. So this would be hyperplastic candidiasis, where this patient's epithelium has now reacted to this like superficially invasive fungal process. I will say superficially invasive because it doesn't get any deeper than those superficial epithelial layers. In contrast, another infectious process is a squamous papilloma. So, we see these, in this case, there's a big one on the palate, but the larynx, the lips, the eyes, the nose, these are all etiologically related to low risk HPV virus, usually types 6 and 11. They can be single, they can be multiple. If you recall, multiple lesions in the upper aerodigestive tract, or I guess upper aero tract of kids, right, might be a sign of recurrent respiratory papillomatosis, right, where these kids acquire the HPV through the birth canal of the mother and then get these deep-seated lesions. I will mention that once you plop these, papillomas out, they generally are not at risk for malignant transformation. They just may recur. You keep popping them out. The risk is when they are deep in the tracheobronchial tree and in the lungs, and they are hard to get out or not unable to resect. Those are the ones that can transform to squamous cell carcinomas in those more deeper seated lesions. So just an FYI, the ones up here, really no worries. The deeper ones are the ones we can start to be concerned about. Histologically, they are these papillary structures or papillary fronds, right, which have a core of vessels and fibrous tissue. That core is generally very thin, and the epithelium at the edge can be quite thick. And when we look at it, we see signs of viral cytopathic effect in terms of coilocytes. So meaning binucleated cells, meaning very wrinkled or raisonoid nuclei, meaning paranuclear halos, right? So this sort of glycogenated cytoplasm that causes the cytoplasm to look essentially clear, right? So those are good coilocyte features that, in addition to the architecture of papillae, can be helpful in the diagnosis. On occasion, we have been asked by Dr. Baruti et al. To test for which HPV type is in these because of I believe vaccines or trying to treat these patients with multiple lesions. So that can be done. We just cannot do it at this institution. So we would have to send that out. But if that's ever something that you guys are interested in, we can do that. Okay. All right. Now going on to some of the more ominous things, I will remind you that, leukoplakia, of course, white, erythroplakia, of course, red, leukoerythroplakia, these are what you have described to us as clinical appearances of that oral mucosa. And so histologically, leukoplakia, erythroplakia may represent a variety of histologic diagnosis. We already saw that something leukoplakic could be candidiasis. Something leukoerythroplakic in a particular fashion could be, lichen planus, right? So a lot of times, if the clinical impression is not certain, a biopsy hopefully will be able to help in that confirmation of diagnosis, ranging anywhere from infectious disease to autoimmune disease to just hyperkeratosis to hyperplasia to dysplasia, even to carcinoma or carcinoma in situ. All right. So we try to be very cautious about evaluating these types of lesions for any of these various processes. So hyperkeratosis essentially just means a thick keratin plaque at the surface of the epithelium, the underlying epithelium of which is essentially morphologically normal or non-dysplastic. And so that thick keratin is what can make it look white. But along with hyperkeratosis, often is associated dysplasia. So we always have to be mindful of the epithelium below that and look for things like disorganization of the basal layer, where the cells, I like to say they kind of look jumbled. Loss of polarity would be the appropriate term, but the nuclei are no longer uniformly oriented. They're kind of pointing in all directions. And you may see some that are large and more hyperchromatic compared to the others, which I'm trying to point out here. Once those features of loss of polarity, increased, nuclear size, variability of nuclear shape, mitoses, right? Once those start to kind of percolate up, midway up through the epithelium, we might want to call that moderate dysplasia. In this case, there's also a large hyperkeratotic plaque on top. And certainly once that process is full thickness, you may want to call it severe dysplasia, or an equivalent would be carcinoma in situ. So severe dysplasia, carcinoma in situ are relatively synonymous as such. So, the thing with squamous dysplasias is that, we try to grade them in this fashion, but unfortunately, anything from hyperplasia to mild dysplasia can progress to squamous cell carcinoma. it doesn't have to go through this progression, right, of mild, moderate, severe, in situ, invasive. Unlike the prototype of squamous dysplasia, which would be the cervix. So cervical dysplasia and pap smears work because the cervix goes through this logical progression from mild to moderate to severe to invasive, whereas the oral cavity doesn't. There are these, causative agents, right, like tobacco, like alcohol, even like betel nut chewing, that prime the mouth. Like it's this, as you know, field effect, right? The entire mouth can be affected by these tissues, by these toxins, and have varying amounts of dysplasias in various sites, some of which progress to carcinoma and some of which invasive carcinoma and some of which don't. And so it can be a challenge. The grading of carcinoma of dysplasias can be a challenge, and the prediction of development of invasive carcinoma can also be a challenge because of this reason. So just keep that in mind. Once we have an invasive squamous cell carcinoma, our prognosis is generally related to tumor size and depth of invasion, certainly, as well as the status of the lymph nodes. I wanted to show you here a picture of a frankly now invasive keratinizing squamous cell carcinoma that maintains these keratin pearls, so-called, that in this case has very abundant perineural invasion. In this case, there's like a core of a nerve in the center with sort of wrapping or hugging of the nerve on the outside, and even nests of tumor within the nerve. Okay, so I think I might do, oops, where did I go? I wanted to just say a couple words on the important prognostic factors that we give in diagnosis of squamous cell carcinomas and staging, because I think these are important concepts for both clinicians and pathologists, surgeons, et cetera, everyone to take into account. So I'm gonna for 2 seconds, I'm just gonna draw something because I think this is gonna be useful. Let me get like a nice dark color here.
Can I ask a quick question, Dr.
Yeah, go ahead.
Cipriani?
Mm-hmm.
So if you can go back a slide,
Yep.
you have mild dysplasia about 30% of the time progresses to cancer.
Mm-hmm.
It just seems, is that like the most updated data? Because I think what we've been taught is that mild is the chance of it progressing, and historically we've been taught it's lower than 30. That seems quite high, but I'm just curious if that's like newer data that's come out or what?
That's a great question. This was taken from the WHO. I think I don't know what the most recent updated edition though says. That's a good question. I will look into it. This was taken from the WHO, but it may be a one version old. I
totally believe it. It's just
And I want to get
yeah, I mean, when we hear mild dysplasia, I think in the OR we often kind of just say, oh, okay, that's fine, like we'll leave it.
Yeah.
But if it's like 30%, that's still pretty high.
Yeah. Yeah, exactly. And so, I think the problem is, when you have a mild dysplasia in a patient that has field effect, boy, that could cover their whole mouth, right? And so like, what are you going to do? Like scrape? How far do you go, right? And so I think that to me, that's part of the problem, right? Is like a lot of these patients have mild dysplasia, multifocal and, diffuse. And so the most important thing is certainly going to be clinical surveillance, right? Because you would want to catch any invasive carcinoma in these patients early, right? So it's a localized resection, low stage, but you can't scrape their whole mouth out of mild dysplasia. Secondly,
yeah, absolutely.
Exactly. When you're already removing an already invasive carcinoma, again, when you see mild dysplasia at the margin, same thing, like how far are you going to go, right? And so I think you've got the main important thing out, and unfortunately it's something we sort of have to deal with. But I completely agree. It's a scary thing. Like you kind of have to almost ignore it, but you got to be mindful of it clinically by watching these patients. Yeah, for sure. Okay.
Thank you. That's very helpful.
Okay, you're welcome. So with that being said, if I can draw on, or what if I share? Oh, can I share a whiteboard? Yes, that's what I'm going to do. All right. Can you see the whiteboard? Or do you still see the PowerPoint?
I see the whiteboard.
Okay, excellent. This is fun. I love drawing in Zoom. I don't know why. I'm crazy. Okay, let me just move this thing over and get. Okay, so squamous cell carcinomas, invasion. So there's a few things I want to point out. So surface of the mucosa here. Surface of the mucosa here. So tumors can be exophytic with an invasive bottom and be deeper, right, than the normal adjacent basement membrane, okay? Tumors can be ulcerative, right, with a bottom that's invasive, right, compared to the normal basement membrane. And so one of the important things for us in these staging of tumors is measuring the depth of invasion. And this is an important thing which you may or may not have come across at tumor board, et cetera. But the depth of invasion is related to the stage, as well as related to the possible presence of lymph node metastases, right? And so if you have a depth of invasion that's, 3 millimeters or more, 3 is sort of the, magic number, where under 3-ish, right, the patient probably has low risk for nodal mets and won't undergo a neck dissection. More than 3 has a higher risk and probably will undergo a neck dissection. But where does that 3 come from? So the 3 comes from a measurement of the deepest point of tumor, okay, in relationship to the nearest intact basement membrane, okay? So we're basically measuring from this to this, and then here from this to this. Why? Because if you regard this exophytic component as part of the lesion, your depth of invasion is going to be increasingly large. And if you if your ulcer is very, deep, for example, then your depth of invasion may be increasingly or decreasingly short, right? So you may under or overcall how much this tumor actually proceeds to invade into tissue if you don't consider what's growing out into the surface and what's being ulcerated, right? So your best acknowledgement of where normal tissue starts is your nearest adjacent normal basement membrane. And so that's where the depth of invasion is measured from. And so this is why on biopsy, if we have a nice, well-oriented, punch biopsy or shave biopsy, where we can accurately measure that depth of invasion, that's very helpful. If the tissue is fragmented and disoriented, it can be very hard to measure that depth of invasion. But once we have a nice resection specimen where we section it perpendicularly to the mucosa, we can, look at these sections very cleanly and measure that depth of invasion. All right. So that's what I wanted to point out there. And so sometimes there's contention, or discussion about the true depth, because this can sometimes be a challenge to measure. The next thing I just want to mention very briefly is perineural invasion. So, invasion around that nerve is going to be more predictive of not necessarily lymph node mets, but local recurrence, right? So perineural invasion, or for that matter, sometimes vascular invasion, will be predictive of local recurrence, right? And that depth will be lymph node mets. Okay, good. Let me go back to the PowerPoint presentation. Okay, anybody have questions on that? Okay, I don't know. I feel like you guys probably are keenly aware of these factors, but sometimes, the pathology residents aren't. And so it's important for me to sort of make sure that everyone is on the same page. Okay. All right, that was keratinizing squamous cell carcinomas. Generally, not related to virus, generally related to those toxins that we saw above. All right, moving into the non-keratinizing squamous cell carcinomas, these tend to occur in the lymphoid-rich areas of Waldeier's ring, that being the adenoid and the other various tubal, palatine, or lingual tonsils, depending on where we're located. Not so much tubal tonsils we see things in, but we definitely see palatine, lingual, and adenoid. All right, so these tend to be in the lymphoid-rich sites. These tend to be associated with virus, either HPV or EBV, as we'll see, and they tend to have a more non-keratinizing or poorly keratinizing morphology. As you can see here, there are sheets of cells without much intracytoplasmic keratin, but they are still squamous by their immunophenotype, okay? So in the oropharynx, so the palatine or lingual tonsil / base of tongue, these are more frequently associated with HPV. In the nasopharynx, the pharyngeal tonsil or the adenoid, these are more specifically associated with EBV, right? So when we see a non-keratinizing carcinoma in any of these sites, we certainly are highly suspicious of HPV or EBV. HPV oropharyngeal carcinomas, as you know, have an excellent prognosis compared to the non-HPV associated carcinomas. And so you've probably seen patients who are undergoing the Optima trials, et cetera, for de-intensified therapy if they are in fact HPV positive. EBV patients maybe have a somewhat better prognosis than the non-EBV associated nasopharyngeal carcinomas. But more importantly, we do want to know the EBV status of these patients because they are often monitored in the serum, as disease recurrence possibilities. So what do these look like? So here's an example of a sort of tonsil to base of tongue, where you see this very blue kind of rotund lesion here that kind of spreads along the surface. This entire area is diffusely strongly positive for P16. P16 being a surrogate marker for integration of a high-risk virus into the patient's genome. So those high-risk virotypes are most commonly type 16, but can also be 18, 31, 33, 45, 54. There's like 18 to 20 of them. Most commonly, it's high-risk 16. This is certainly mostly presenting in middle-aged-ish men, but certainly can be in women. They often, as you know, present with these cystic lymph node metastases, and then, the primary is subsequently found. But if this all, pans out, these patients generally have a good prognosis, unless they have some other confounding factor like smoking or other high-risk behaviors. So this is a non-keratinizing HPV-associated carcinoma. You can see the surface up here is generally intact, but this tumor is this sort of large, broad-based nest below. Surface dysplasia in these cases may not be present. Sometimes these arise very deeply in the tonsillar crypts, and so the surface might look completely intact, and the tumor is only below it. These can range from being very large, filling the tonsil, to very small, sub-centimeter microscopic foci. We talked about P16 already, but just as a reminder, it is a cell cycle protein that is upregulated by integration of the virus. When the virus integrates, it transcribes its two main oncogenic proteins, E6 and E7. E6 basically knocks out P53, and E7 basically knocks out RB. So it is knocking out your two major tumor suppressor genes, which is why it's such a potent carcinogen, okay? So you basically have eliminated your sort of genoprotective function. You've eliminated your cell cycle check. So these cells just rapidly proliferate, and that's often evidenced by the, high number of mitoses, implying rapid growth that these tumors have. So the P16, because of that genomic integration, is backwards upregulated within the cell. So once we see a positive P16, we generally do a confirmatory process like an in situ hybridization for the E6, E7 messenger RNA, or PCR for the high-risk HPV DNA. If you have a P16 positive lesion that is outside of the oropharynx, this should not necessarily be regarded as an HPV positive lesion, because in the oral cavity, in the larynx, in other sites, P16 certainly can be upregulated for reasons that are not related to the HPV virus. So we just had a case the other day or the other week that was like a epiglottic lesion, and it was carrying a little bit onto the base of tongue. A P16 was performed by the outside institution. It was kind of moderately strong, and HPV is negative. So when you see P16 in a site, P16 being positive in a site that is not this characteristic site, always would want to do a confirmatory test to determine whether it's positive or negative. If you are in the appropriate site with the appropriate morphology and the appropriate diffuse P16 expression, then you're pretty much guaranteed that it is HPV positive. Okay.
Can I ask another question?
Yeah.
So say you get, an oral tongue cancer, like here, do we even run P16 or would why would we run it if we have to confirm it anyway? Why don't we just go straight to the PCR, or do we do that anyway?
So we don't even
do we
run
go straight to PCR?
So two-phase answer. One, we in this institution don't run it. We only do P16 or HPV testing in essentially these oropharyngeal lesions. Because if you do it outside, like you're saying, and it's positive, then you probably would want confirmation. And what are you going to do with that knowledge? Like, we don't really know how HPV cancers outside of the oropharynx function. We know that they exist. There are examples of oral cavity HPV cancers, but there's so few of them that they certainly won't undergo any clinical trials, and they will likely not undergo any de-intensified treatment because we don't know how they're going to behave. And so exactly. So we don't even do it because it's not going to change clinical management. The challenge is when twofold, when you have a lesion that's bridging multiple sites. So it's either, bridging the base of tongue and going forward to the oral tongue, or it's bridging the base of tongue and it's going backwards, into the, anterior surface of the epiglottis or valleculae or something. Those are the cases that can be challenging, in which the actual, site of origin may not be clear. And so it's those cases that are bridging sites where we will do the test and the confirmation. P16 is often done first in those settings because it's cheaper. So an immunostain is cheaper than an in situ hybridization and cheaper than a PCR. And if it's negative, you're done. Like, if it's negative, there's no way this can be HPV. So that's the reason why P16 is generally done first. But I understand your question.
Really helpful.
Cool.
I have one other question. I apologize.
Nope.
So one thing that I always find interesting is that the HPV associated oropharyngeal cancers, or EBV NPC, is non-keratinizing but has a better prognosis. So should we not think of keratinizing in terms of what more well differentiated? Because it seems like, to me, it seems like if it's squame, it should be keratinizing. That would mean it's like more differentiated, right? But those also have poor prognosis. So I was wondering if you could just comment on that. It seems like you want to have less differentiation.
Right.
But
you hit the nail on the head. And so this slide is kind of addressing those questions. So yes, correct. I will mention that, but I will go back to P16 for a second. So
no problem. Thank you.
Yep. The other case in which P16 is a problem is when sometimes, I don't mean to be rude, but sometimes there are smaller institutions in the local area that are not so up to date on the recommendations and actually perform P16 on everything. So we will see P16 coming in from consults, on lateral border of tongue. And it's useless. It's useless. And so therefore, the College of American Pathologists came up with a consensus guidelines, which was affirmed by the American Society of Clinical Oncology. So the pathologists and the clinical teams are all on board, We will only perform high-risk HPV testing on oropharyngeal carcinomas, nothing outside the oropharynx because of the problem that you were getting at. We will not perform that testing on any tumor that is arising outside of the oropharynx, okay? And we will not provide a grade or differentiation status for these tumors. So exactly as you said, non-keratinizing carcinomas used to be called basaloid, used to be called poorly differentiated, implying a poorer prognosis. Keratinizing carcinomas are often considered to be well differentiated, but you exactly hit the nail on the head, because now, at least for the oropharyngeal non-keratinizing squamous cell carcinomas, these groups have recommended not grading them. So we do not call them poorly differentiated because it is not reflective of their good behavior. We in this institution, Mark and I, also do not grade keratinizing carcinomas for the exact opposite reason, because they generally are bad. Whether you call them well diff, poorly diff, moderately diff, they appear, oh, they are keratinizing, they recapitulate normal. Nope, they're bad. Like, exactly. So we don't grade any carcinomas of squamous origin here anymore for those exact reasons, because we have better indicators of behavior. We have a great indicator of HPV positivity in the oropharynx being a good prognostic marker. We have great indicators of things like perineural invasion or, depth of invasion as being bad prognostic indicators for keratinizing carcinomas. So we use our other tactics to help manage these patients rather than the grade or the differentiation status. Hopefully that makes sense.
Perfect. Thank you. That's great. Yeah. Thank you.
You're welcome. I think it's important to ask these questions and not just do things blindly, And so again, reports coming from outside institutions often do grade both keratinizing carcinomas, and I sadly still see some non-keratinizing carcinomas that are also being graded, and we don't do it anymore. So I think for the reasons I've already mentioned. Okay. The one area that we will test something where it may or may not be an oropharyngeal primary is if you have a nodal met, right? So if you have a cancer of unknown primary, those also are tested for HPV, because then if they're positive, you know where to look. One word, I know it's late, I apologize. One word on the EBV. So EBV to me is kind of the correlate of HPV oropharynx, EBV nasopharynx. Similar morphology, viral integration. In this cases, we generally do EBV in situ hybridization, as you can see here on the bottom left. There are very rare cases in the nasopharynx that are EBV negative that may be HPV positive. There are also cases that are both EBV and HPV negative, and those are, again, more of just the conventional keratinizing types, okay? So that's EBV can also present as a neck met, but it's just more rare in our environment. We see it less often. With that, I will stop. I won't go into the larynx because we're over time, but hopefully that was helpful for you guys.
Thank you. This was very helpful.
Yeah, thank you. It was.
You're welcome. Great to see
Thank
you
you.
guys.
Do you have more coming up? More lectures?
I have one more. Let me see.
It'd be helpful if you maybe do like some salve.
Okay.